And welcome to our cardiovascular imaging conference. I'm Dr. William Zoghbi, the Chief of Cardiology here at Houston Methodist, and it's a pleasure to welcome you and to join us for the topic of today is contrast echocardiography, or also called ultrasound enhancing agents. The topic is very germane because nowadays using ultrasound enhancing agents or even agitated saline is part of your armamentarium to diagnose better cardiovascular disease, enhance images. So you need to know the basics. It is unique for ultrasound because these ultrasound enhancing agents or even saline agitation interacts with the ultrasound beam. So it depends on your settings. If the settings are not most optimal, you're not going to see the best images. So be it you are a sonographer or an echocardiographer or an interpreting physician, you really need to know these nuances. So if you're on the interpreting side, you should be able to find out whether the contrast agent was given appropriately. Was it too much, too little? And how do you interact with your sonographer or whoever's taking the images to optimize these images, okay? So this is unique for echo because most of the time when we use contrast agents, the contrast per se is not affected as much by the imaging technology, be it CT or MRI. So I think it's important to take a look at the details. What has been used for years and years, back, to tell you the truth, back in the late 50s, early 60s, is the discovery that if you have tiny microbubbles in the fluid medium, it reflects ultrasound. It looks very well, just like you're seeing on the side. So it reflects it, and we use these properties for agitated saline to look for shunting, intracardiac or intrapulmonary shunting. And why? Because these agitated saline, and it could be just like you see on the right side here, you could shake the fluid and it could be just saline itself with a little tiny area of air in the hub of the syringe itself, back and forth, to create microbubbles. And these microbubbles are larger than with the developed ultrasound enhancing agents. They are usually about 10 microns or so. And the interesting thing is they don't last too long, and they're large enough that they're caught up by the pulmonary circulation, so ideally you shouldn't see any contrast going to the left side, be it intracardiac or intrapulmonary. However, notice in this nice, beautiful case here that you have a patent foramen ovale with intermittent shunting, and you could see the interatrial septum being bulging from time to time during respiration. And you'll see a little puff of contrast coming on board, and then that puff goes away. And as opposed to intrapulmonary shunting, where it starts a little later and continues to build on the left side. So that's how we use agitated saline to help us diagnose patent foramen ovale. And remember that patent foramen ovale is diagnosed whenever the left atrial pressure is a little lower than right atrial pressure. So it varies with respiration, Valsalva, et cetera, and it's intermittent. Now, you could use also saline contrast for enhancing tricuspid regurgitation jets. And they could be tiny. They could be, some that you don't even see. But you could enhance it to be able to evaluate what RV systolic pressure is using the Bernoulli equation and PA systolic pressure, etc. So these are the use of agitated saline, which is obviously very, very cheap and available and could be really important from a diagnostic point of view. Remember also, since we're talking about saline here, diagnosis of patent foramen ovale is probably best for detection purposes in the awake patient during transthoracic examination as opposed to transesophageal examination. Again, because you are depending on the right atrial pressure to be a little higher than the left, and you could induce that if it is not just present at rest. You could induce that with Valsalva maneuver, which you cannot do as well with a transesophageal. So we use transesophageal to delineate where the shunt is, assess the size of the PFO, et cetera, but it's not your major diagnostic screening for patent foraminal valley. Okay? So these tiny microbubbles that are 10 microns and maybe lower are affected by multiple factors. So think about it as a little shell with some gas inside the cell, which could be air in your agitated saline or high molecular weight gas. And tell you the truth, I grew up in this field where there was experimentation as to what is the best molecular weight gas, inert gas that is non-toxic. And two is, what is this shell that you're talking about here that could be, strong enough to withstand pressure from the outside. The early, ultrasound enhancing agents were very pressure sensitive. So every systole, contrast almost disappears. So it breaks them in every systole. And then, in diastole, ventricle fills. We see much less of that. Nowadays, they are less sensitive to pressure. And we have currently approved in the United States 3 agents that are used: Optison, Definity, and Lumason. And you could see them, the manufacturer, the size. Look at the size. At most, maybe 4 microns or so, usually above 1.5 to 3 or so microns. These are the shells, denatured albumin, lipid monolayer, which at times can cause an allergic reaction. So you got to be careful about that. It's very rare, but you can have an anaphylactoid reaction with these agents. That the treatment is similar to anaphylaxis. Fluids, epinephrine, et cetera, just in case, but this is very, very rare. But I think as a sonographer or a physician dealing with that, it can happen, and you could develop that allergy. The others are, more available even in Europe and others, but I think we have plenty to be able to do that. Early on, the uptake of utilization was very, very slow. Nowadays, much better than before, and it took a lot of education to assess, validate the impact of such agents in our day-to-day practice to enhance, basically, the major indication is enhancement of evaluation of left ventricular function. That's the only indication nowadays approved by the FDA. If you have 2 or more segments of the heart that you're not seeing, that you need to see for whatever reason, mostly evaluation of regional and global function, that's what you would do. Okay, usually we do not show images so bad, but I think this is where contrast is important, right? You tell me how much you can interpret from this heart. You could see some silhouettes, you could see maybe the left atrium, etc., but you can't see much. And the beauty of these contrast enhancing agents is they really enhance the situation. You could see now the heart, you can quantitate, evaluate regional function, etc. Truly, very impactful, no question about it. And you could do it in the same setting. So from a effectiveness point of view, from a flow in laboratory or now, remember that the vial or whatever you draw in your syringe has so much concentration of tiny microbubbles. If you're sending reflecting it off these tiny microbubbles, if you ultrasound, it's almost like calcium thing. So you have to have enough concentration to opacify, but not too much concentration to attenuate and reflect all the ultrasound. So what I have here for you, and I've used all I have an example of an injection. Okay, so obviously contrast is going to go to the right side first. It's going to go to the left side. And you'll notice that the injection is either forceful, too fast, or has too much concentration, meaning has not been diluted. Most of the time we dilute even any of these three agents that we talked about in about 10 cc's, and you don't inject like a very fast bolus. After a while, you will figure out, few cc's per, few seconds here. So now notice also, and that's what you're going to see, the ultrasound beam is coming this way. These are the scans, right? The right side is here, and the left side here. You're not seeing much because for you to see ultrasound, you have to decrease your mechanical index, which is the energy that is sent to the heart from it to be reflected. So I barely can see the heart, and I'm concentrating mostly on seeing what happens with contrast within this cavity. So let's play this. Let's see here. There you go. So first contrast is coming to the right side, and you can see a sliver. It is filling the whole heart, but it's attenuated. Watch now the contrast coming to the left side. I see more and more. And what you're going to see is quite a bit of attenuation. This is reflection of most of the ultrasound in this wave of contrast that's coming into the left ventricle. So you see black here, not because there is no contrast, actually because there is too much contrast. Okay? So notice that the tip has a lot of contrast in it, and this wave has gradually grown into the left ventricle because this wave of contrast came in very strong. I'm going to play it one more time, just for you to notice that. Okay? And part of the reason that you only see a sliver from the right ventricle is, again, the same phenomenon of attenuation. I have too much contrast here. I'm going to see only a sliver. And notice here, more black, more black, more black, and basically just a sliver here. So what do you need to do? Just going to have to wait for the concentration to come down a little bit. You could destroy microbubbles by increasing the mechanical index, and we'll talk about it. But here, basically, whoever is injected, okay, need to recognize that the injection was either too forceful, too fast, so you have to slow down a little bit on that so you don't have as much of this attenuation. Any questions regarding that? We're good? Mechanical index. I think this is one of the numbers that the novice or even no novice has to take a look at it in your display. It usually is in this display of the ultrasound, features. It's called MI, or mechanical index. It's the peak negative pressure divided by the square root of the frequency of the ultrasound that you're sending. What's the importance of it? The higher the mechanical index, and high, we're talking about 1 and above. We're not talking about hundreds numbers. Low is like 0.2, 0.1. So this is the range from 1.5 to 1.1. If it is on the high side, you're setting a lot of energy. And remember, ultrasound is characterized by waves of high pressure, low pressure, high pressure, low pressure. So if you're talking about insonation of these tiny microbubbles, at the high pressure they're going to be compressed, and at the low pressure they're going to expand. And what happens with them? Obviously, it is not the high pressure that is destructive, it is the low pressure that expands and basically breaks that little membrane that you have around. So if you want to destroy, you image at your regular, which is 1.5 mechanical index. You can destroy a lot of microbubbles, and we're going to go through them. It's not going to look appealing to you because it's fragmented, it is black and white, it doesn't opacify the ventricle well. So you need to recognize this. So nowadays, most ultrasound machines are preset with contrast settings that decreases the mechanical index and tries to optimize them. These are done for 2D, not as well as for 3D, and we've been appealing to industry to make sure that we have some settings for 3D. Yes, you destroy more because in 3D you're sending ultrasound beam not in a single plane, in a cone-like situation. So you send a lot of energy and you'll destroy a lot of microbubbles, but I'm pretty sure the engineers will figure something out to enhance this and utilization of contrast with 3D echocardiography. So what I mentioned to you, see, this is the scale of power or mechanical index of the incident beam. Low MI is at about 0.3, and actually it can go even 0.1, whatever it is. And your visualization is that I want to make sure that I'm not destroying too much of these contrast agents. High mechanical power, 1, you will destroy quite a bit. Usually you don't have to play around. You know, if you have too much, you just wait a little bit, it will dilute itself, and next time don't inject, you know, as fast or as much, okay? So let's try to illustrate the effect of a mechanical index on these ultrasound enhancing agent intensity and duration. So what I have here for you, okay, is you see it's a harmonic, and you see the mechanical index is like almost 1.5 or something like this. I'm going to decrease the mechanical index from very high to low, and notice what would happen with the opacification of the ventricle. At a high mechanical index, there's going to be a lot of destruction, and what destruction looks like, it's almost like a hurricane. Why? Contrast is coming in with a nice intensity. Gets destroyed. Some of that destruction goes black. So you're going to have a mixture of contrast and blackness. There you go. High mechanical index, see how it is? In systole, you almost have emptying of it. I'm going to start decreasing it right here, mechanical index. Notice now that I have full opacification. I'm back to the high. Notice I'm going to start decreasing it, and you're going to have full opacification and less of this hurricane effect. Okay? So this is only for demonstration reasons. You're not going to, as acquiring the images, you're not going to go and play with it. This is mostly for demonstration. So that if you see something like here, this is not low contrast. If you see a hurricane-like effect in a normal ventricle and the base has good contrast, you know that you're destroying a lot. So you take a look what the MI is like, and you suspect that the MI is high, destroying quite a bit of bubbles. Okay? Now, the neat thing is, you heard about harmonics, and you know that very well, is traditionally, I mean, talking traditionally here more than 25 years ago, 30 years ago, used to send for imaging a certain frequency called fundamental frequency, and you would image, or whatever is reflected back will be at the same frequency. So I send at 2.5 megahertz, and I'm listening at 2.5 megahertz. Now, part of the discovery is people were looking at contrast, and we were actually among, you know, the first centers to Jorge Sharif, who's now in Dallas. You know, we discovered the attenuation portion. We did a lot of animal experiments, et cetera, et cetera. And people have discovered that if you, these microbubbles resonate, okay? So just imagine I have this tiny microbubble, I hit it with some ultrasound frequency, it sends multiple of that frequency back. It resonates differently. I'll give you an example that you do that. If you're an instrument player, either piano or string instrument, if you hit it at a not too hard of a stroke, it's going to emit that frequency, whatever that frequency, C, G, whatever. Okay? But if you hit it very hard, it emits its fundamental frequency in addition to multiples of it. And you hear it similarly to, instead of bang, it will be bang, something like this. Okay? So same thing is with microbubbles. So here, this is the fundamental frequency, and this if they have a non-resonant structure. But if you have a resonant structure, it will emit multiple of that frequency. And interestingly enough, it can also do half of that frequency. But the vast majority are here. So people discovered harmonic imaging. Harmonic imaging was preferentially to develop contrast, to enhance the contrast itself. So I emit at 2.5 and I listen at 5. Why? Because I'm going to listen mostly to try to enhance what is coming back from these resonant structures, which is contrast. Okay? So this is illustrated here on the right side. 2.5 is the emitting frequency. These bubbles will emit 2.5 in addition to a 5, which is a stronger signal. Okay? So let's take an example here. All right? This is fundamental versus harmonic. So if I have contrast in this beat, or these sequences of beats. I have contrast in there. And I'm going to flip from fundamental to harmonic. You see here 3.5 megahertz. And occasionally you're going to have an H, which is harmonic, meaning I'm listening at multiple of that frequency. Notice the difference in image quality. I'll start prefacing it that actually the image that you are seeing right now on still is fundamental, is not pleasing to the eye. You cannot differentiate myocardium well from cavity, right? They're about the same. Notice what will happen when I flip to harmonic. This is like sequential beats. I'll not change anything. Okay, let's do it. If we can. There you go. Harmonic. Fundamental. Huh? Isn't that impressive? It's quite impressive. Nothing has changed. And why? Because the tiny microbubbles emit much more of the multiple of that frequency, harmonic frequency, as opposed to the fundamental frequency. Now, interestingly enough, along with this discovery, initially it was felt that myocardium doesn't emit harmonic, and actually it does. That's why you image nowadays most of the time with harmonic imaging. It improves the quality, takes away some of the clutter. So the signal to noise ratio is better even with regular imaging without contrast. But if you want to use contrast, you could tell that you need harmonic to enhance the signal compared to the myocardium per se. Okay, so what is approved for use of these agents in the United States is endocardial border definition. I told you, 2 segments or more that are not seen, from any window, usually the apical window. We use it also for enhancement of Doppler signals. A lot of research in myocardial perfusion, still much more experimental and in animal models, some for therapeutics actually, so we can talk a little bit about them, in general. 2 documents for the American Society of Echocardiography. I think the last one is 2018 or so. And I think it's very important for your reference to take a look at that and see what are the various applications of ultrasound enhancing agents. This is, in a summary, what the applications are: improved endocardial border definition, regional global function, delineation of LV hypertrophy. Remember, we teach that LV hypertrophy, particularly from the apex, apical window, you have a lot of dropout and you may not see it as well. Uninterpretable studies, particularly in the ICU, true rescue in the vast majority. Stress echo, not an indication at this stage of the game, but we use it for the same reason, to enhance ventricular function if you're not seeing it. Just as an FYI for you, Dobutamine is not approved for stress testing. So we use it off-label for such, similar things here. Doppler signaling enhancement for aortic stenosis at times. Don't overdo it there if you have a good signal. And definition of structural abnormalities. You have a thrombus or pseudoaneurysm, you want to think about flows, or you want to make sure that you don't have a thrombus. So this is appropriate use criteria. We talked about it already. Another example, I wanted to make sure that I show you a split or previews kind of screen that no matter how you looked at it, you can tell really ventricular function. Now you can't tell. And that's the impact of it. The impact of it is if I don't see the heart well, I'm not going to be able to interpret this heart well. This is another example here. I think most of us would recognize that this is poor ventricular function. If you tell me, what is the wall motion in every segment? I cannot tell you. I know some of them are akinetic. Some of them are not as bad, but that's all what I can tell. And I know the ejection fraction is depressed. And the question is it enough? Right? Is it enough information? Turns out, in this particular case, it's not enough information. Because I knew the ventricle was depressed, but there is a sizable thrombus in the apex of this heart that you can see very nicely there at multiple views. And remember, for you to be able to see thrombus, you need to scan this cavity. Remember, most of the time thrombus occurs in an area of regional or global dysfunction. And whenever you have such, then the area that you need to interrogate is very large. So if I'm concentrating on a plane or just a couple of planes, I may miss the apex itself. So you want to make sure that you scan in different directions, that you cover all the area of interest or in jeopardy. Okay? Interesting kind of situation here. I can tell that ventricular function is good. I cannot tell how much is inside, right? Really can't tell more than this, and you need to know. And what I know here is I have an individual with a very thick septum. It's a hypertrophic cardiomyopathy with the asymmetric type, and the diagnosis is very different. So the message is, if I don't see well, I need to see in the same setting. Don't do it after the patient is gone. You have to make sure that you take advantage of the situation, use it appropriately whenever you need it. I'll never forget this case. I always show it because it's very interesting how the eye, interprets and extrapolates things, right? So this is a case that came quite a few years ago, and Dr. Kleiman called me and said, this patient has a very abnormal electrocardiogram. I really don't think wall motion is normal. So could you please look? And that was at the early days of contrast use, so we used contrast, and a very unusual kind of situation, because what happened is, I personally read this case as I extrapolated this area, but this area turned out to have a large aneurysm. Very unusual location. You could see it here in the anterolateral area, very focused, as opposed to your apical area. So I think agents nowadays are much more available. People are much more comfortable with it, and what you're driving for is quality of the interpretation, basically, of the total. I mean, this is the same study. You're going to have to decide when to use it, particularly when you're not sure about what you're seeing. This is a case. Actually, we were doing a live demonstration a few years ago, the Heart House. Patient came in the night before. You could see these with chest pain. So ischemic, non-ischemic, can't tell. Certainly a very abnormal electrocardiogram. And if you take a look at the baseline echocardiogram, you cannot really tell whether there's an apical abnormality where you could have an apical, ischemic defect, yes or no. And it turns out to be actually is the apical variety of HCM. Not even a sequestration of an apical cavity, but the ace of spade is very prominent here, and it turns out to be an apical hypertrophic cardiomyopathy. All right. Take a look at this case and tell me what you think. How are you gonna interpret this case? Anybody, and you don't have to use the microphone, I'll repeat your answer. All right, anybody? Oh, come on. Basal anterior, inferior, yes. Basal inferior wall is akinetic. I got it, right there. Okay. Anything else? There's mumbling. Apex is akinetic. Maybe. Are you sure? 100%? Huh? Four chamber? Yeah. Conceivably. All right. More obvious with also the hinge points of where the apical akinesis is. And what else do we see? We see a clot there. So that's the importance of it. And at times, you'll be surprised if you're not seeing. So whenever you have wall motion abnormalities, concerned about other things, I think it's really very appropriate to do that. Okay, what do you think about this case? Interpret this case for me. Incomplete silence, but it appears like apical HCM. And why do you say that?
I see more hypertrophy at the apex and kind of collapsing of the cavity at the apex.
Yes, I mean it looks like more hypertrophy at the apex. Hard to tell on the parasternal long, but here, as I say always, there's also the outside border of the heart that is not coming into the ventricle. The differential is two things. Either akinesis in the apex that you're not seeing, or too much muscle that you have no motion, right? So you could see the difference here, right? On the outside, the epicardium moves, epicardium doesn't move as much. And it looks like, so whenever you have what looks like an apical abnormality here and you cannot see, this is your apical hypertrophic cardiomyopathy. And you could see some arterioles come in there, you could see the contrast coming in, and at times you may see an apical sequestration, which also is it's a mid-cavity almost obliteration with apical sequestration that becomes problematic. It may grow into an aneurysm, and actually it has arrhythmogenic properties, sudden cardiac death. And there are some institutions that just go for an ICD immediately as opposed to other things. So more and more data is coming regarding that. Actually, we were the first to describe, my goodness, 1986 or so, 87, American Heart Journal, the flow dynamics of mid-cavity obstruction with in 3 cases. And some of them were not HCM. Some of them were just hypertrophy and hyperdynamic kind of situation. All right. After what we went through, tell me what you see from a technical point of view in this image. Can you analyze these 2 images below? What is this image and what is this image? High MI where? This one. High MI, and this one? Too much contrast. So what did they do? Huh? You know what they did? These are sequential. They realized they gave too much, and they would not want to wait another minute or 2. Increase your MI, so you go from one extreme to another. Then I need more contrast. Right? So the best in those situations is just wait a little bit. Right?
At least they got the Doppler though right after.
I'm sorry?
At least they got the Doppler after the MI was increased, so you don't have to.
Yes, they got the Doppler afterwards, indeed. Right? So, okay. Aortic stenosis. I think most of the time you should not use contrast. If you get a good jet, don't use contrast. You know what would happen is you would increase the velocity early on in the contrast, so you got to be careful. You will overestimate the gradients. Okay? So please don't do that just to push an intervention on a patient. You only use contrast when you need it, right? Just like maybe this case where it is not really nicely, identified, and here you could see it very nicely. And the ones that you record are after the contrast has almost died down, so you don't see this blooming effect from the contrast per se. Okay? So potential impact of contrast we did this slide many years ago, it has not changed. Inpatient setting, ICU instrumented patients, definitely. Stress echocardiography, very important there if you don't see well. If you're struggling at baseline, you make sure that you get contrast at the baseline in addition to stress. This is very important. This is a study we did many years ago with fundamental imaging, harmonic plus contrast versus TEE in the ICU, to tell you about the impact of contrast. That's from Dr. Young, who's I think still probably is in Corpus Christi. And you could see that contrast plus harmonic is very similar to transesophageal echocardiography in identifying ventricular function and some regional function of the heart. For stress, and we talked about it, that it is not a current indication, approved indication, it's an off-label use. And the advice for you there is, if you have to decide on use of contrast at the beginning. If you're struggling, if the images are not the greatest, you remember the images will get a little worse with time and with stress. So if it is borderline at baseline, this is the time to use it. And the current utilization in the US, I think is still between 0 and 100. It has improved a little bit. I'm against the 0 and I'm against 100%, because actually there are data to tell you that you're going to need it depending on the patient population, and you should not use it indiscriminately, because if you have beautiful images at the baseline, they may somewhat deteriorate because of attenuation and because of linear artifacts, right? So it's very important. And we did one study actually, Juan Carlos Plana, when he was a fellow with us a few years ago, time's flying. We did a study that I don't think we're going to be able to repeat, just because of the sheer needs of what happens is we did 2 dobutamine echoes, randomized, 1 dobutamine without contrast and another dobutamine with contrast. And a decent population tells you about, if you had enhancement versus no enhancement, the number of segments that you visualize is much better, 94%, and stays the same at rest and stress. Notice that if you didn't use contrast, the visualization goes down compared to rest. So I think that's important. The effect of visualization on agreement with cath. So these are patients who had cath. It's very interesting that is similar to the rest indications. If you had more than 2 segments that are not visualized, and this is in any window, it's not only apical window, concordance is better. If you have 1 to 2 segments visualized, almost the same. If you have all visualized segments, really there's no impact, and that's what you would expect, right? So take a look on the left side, and you tell me, this is a stress dobutamine. This is actually one of these patients. How do you interpret it? This time there is silence. Anything. Is it normal or abnormal? In truth, I think it's abnormal. I know you're non-committal today, but that's okay because you may be hypoglycemic. But I see a probable apical abnormality here. So the question is this a new abnormality? Yes, no. What is the ventricular function? Yes, no. Can't tell much. And if you, as an interpreter, are going to say to your referring physician, technically adequate study, there is apical, ischemia, how much are you interpreting between the lines? A lot. How much are you stretching? A lot. And that's okay. If you end up with such a study, that's okay to say, technically difficult study. There is a suspicion of an abnormality there, but I can't tell. Then the physician, referring physician, would know what to do. They have to do another test. They have to do something else, right? Okay, this is the same case who had contrast. So this is the same patient, another dobutamine with contrast. How do you interpret it? So number one, you can interpret it this time. How do you interpret it? We're not here forever. I'm sorry? There is a problem at baseline. So we got akinesis of the apex at baseline, right? And what happens to this heart with increasing dobutamine? Got worse. Dilated, right? With extension of the wall motion abnormality. So this is a previous infarct on top of ischemia. Very different interpretation. High risk, right? So all we're saying is use it appropriately, right? And part of the reason, if you have beautiful echocardiograms, not to use contrast is what you see here. I always teach that if you have a linear configuration of a structure in the heart, in the left ventricle, it's either a tendon or an artifact whenever you see contrast, right? And notice, see this shadowing of contrast from a structure here. The endocardium is way down here, and you gotta be very careful about your interpretation. Your eye will be fooled, okay? Same thing in this portion of the inferior wall. This is a shadow from the papillary muscle, another shadow from the papillary muscle. The endocardium is way down here and is abnormal. So you got to be very careful. How do you interpret it whenever you start seeing shadowing? Yes, it improves overall visualization. See, this is another linear density. Endocardium is way down here. Same thing here. Okay? So be careful when you use contrast. How do you interpret the images? And obviously you'd use multiple windows for you to be able to interpret the images. So contrast, it improves your visualization, improves your accuracy, and most likely, the utilization will be somewhere between 50 and 80%, something like this, depending on the patient population that you're using. And the other, point that I want to mention to you is the impact. And I think that's, there are several studies. One of them is from our own. My goodness, time is flying also. This is from Dr. Kurt when he was a visiting student from Turkey. And we were so impressed with him, said, stay another year. We have a project for you. And indeed, that was a very important project. More than 600 patients that were deemed that they required contrast echo for, and this is in different settings, ICU settings, whatever it is, inpatient, outpatient, and to look at the impact. And what we did not want to do two different studies, so we interpreted the first study without contrast, then the sonographer gave contrast, or the nurse, and we asked the physician we told them what the result of the non-contrast study and what would they want to do. And then we gave them the result of the contrast study and how would they change, if at all, their management. And I thought that was clever. I like that. So this is the impact on visualization here, on quality. So by definition, the vast majority were technically difficult for us to, and look at what happened afterwards. And this is in the inpatient ward, MICU, SICU, outpatient. Yes, not all of them were adequate. Yes, some of them were still technically difficult, particularly in the surgical intensive care unit. And a lot of patients were instrumented with many instrumentation. But the most important thing was the impact on additionally planned procedures. This is TEE avoided in blue, nuclear imaging avoided in yellow, and no procedural change. Notice that the vast majority of the impact are in the intensive care units, no question about it. It's almost more than 50% impact, particularly in the surgical intensive care unit, where you do the study, you can't even tell what the situation was. And the least is in the outpatients. Not to say it's nil, but certainly, you know, depends on the patient population that you see. Impact on medication changes. Hemodynamic drug started because ventricular function was underestimated. Hemodynamic drug stopped because it was actually too good, probably hyperdynamic. Anticoagulation stopped because it was suspicious of a clot, or started, depending on what you saw. And I think these are very important impact. And the interesting thing is that you could do this at the bedside while you're doing this. And this is the overall impact. Vast majority, you know, close to 60% or so in the intensive care unit, surgical more than medical, inpatient wards not small, and in the outpatient, you know, the smallest impact. And that's what you would expect. That's also makes sense. Number of non-visualized segments before contrast and their impact. If I have the vast majority of my heart not seen, almost 100% impact, and somewhere in between a graded impact as to what the overall, you know, situation is. Is this thrombus or reverberation? Sam, what do you think?
I'll comment after contrast. It looks like thrombus.
It looks like thrombus. Everybody? Even the experts say most likely thrombus? Can't tell, really. You cannot tell. It could be thrombus because it looks moving, but I don't know where the pedunculation is. If you're stranded on an island without contrast, what do you do? Huh? What do you do? Move the focus down. Say that? Different views, very important. Different views. I could still see the apex from a parasternal long, aiming towards the apex, and I'll still see it. I do a short axis all the way to the apex. And what's another thing that you could do? That you should do if you're stranded on an island? Color Doppler doesn't help, because whatever filters you're going to do is going to fool you. Change transducer. I mean, nowadays, I know you like your transducer because it has multiple frequencies. In the past, a 2.5 transducer was fixed, 3.5 was fixed, 5 was fixed, so you had to change every time. Now it is multi, so you can change the frequencies, and if you have a different transducer, you should change it. But these are the things that you would do to make sure that indeed. And here you go, Sam, that's just for you. No thrombus. No thrombus. How about this one? You may be a good quiz taker. And what's unusual about it that says maybe it's not a thrombus? No, I mean, the ventricle is heavily trabeculated. See this? All the way, and the question is this a thrombus, yes or no? Yeah, but fixed, you could have, remember, quite a bit of this is reverberation from the transducer. That's why you change transducers also, right? Because if you have something that reverberates back, so you're going to have back and forth, and then you have, you know, this. Harmonics takes care of that usually, improves it. Okay, let's see if Sam is correct. It's there. It's real. Okay? How about this one? Priyanka. This is a tough one. This is a tough one.
The entire LV looks like it could be thick, so I'm wondering if, I can't tell if it's not could be thick.
It's good for you. It's good for you. I think you can't tell. Now let's see if there's a surprise. Isn't that amazing? That's really amazing. Quite a bit. All right. Myocardial perfusion, I'll just say a few words about it before we leave here. One is, you know what the velocity is of blood within the cavity and through the valves, right? It's in cms per second. Could be 100 cm per second, could be more, right? You have an idea what the velocity of blood in the capillaries is? Dr. Talawi. In millimeter per second. Millimeter. Which tells you what? It tells you that if ultrasound is sensitive, I mean, if contrast is sensitive to ultrasound, it would be dwelling too much on these tiny microbubbles. Exposure is too high. And that's why you do not see, unless you do a manipulation, you don't see well contrast in the myocardium. You understand that? Because the exposure is too high. You know, these same tiny microbubbles are moving very slowly and the exposure is too high. So here you go. For me to be able to see it, I could do intermittent imaging. Intermittent, I know you don't do that. You could see how dark the myocardium here is compared to contrast within the myocardium. So I replenish it. I destroy it and replenish it. And you know, there's some investigators who did all their academic career on contrast echo, including Dr. Kevin Way and Sanjeev Kaul and Jonathan Lindner and Dr. Villanueva, who is in Pittsburgh. And some of them, actually, the three of them are still using contrast for this kind of work. So you could quantitate flow, but you have to image intermittently and watch this contrast, which is analyzed by intensity, coming into the ventricle, and then you could measure myocardial blood flow, how much flow there is in the myocardium. And we did that clinically. It's much more tedious. It certainly is used nowadays still in the laboratories for understanding physiology, because you could do multiple injections as opposed to radio-labeled microspheres, et cetera, et cetera. So for us to be able to see contrast, you have to lose low mechanical index and a very slow frame rate so that you don't basically destroy them. And there's destruction and replenishment. You could see that very nicely. High MI will destroy them. And you could see here very dark, and then gradually you can see them. So you can study perfusion. Part of the problem is some attenuation in the base. You may not see it as well. Here there's perfusion in the base, but you could see it's dark. Here and there's heterogeneity. So there are technical issues. We've done a lot of work with it, but I think nowadays this is much more. I know Dr. Tom Porter uses it quite a bit in his lab. But you could see, the variability in overall interpretation. Okay? So, what is the future? Education, I think, much better now than if you tell me 10 years ago, 15 years ago, although the agents are still the same. I think you could use it nowadays. Many of the trainees are very comfortable. Sonographers are comfortable with it. Wide variation is getting better. I'm talking about utilization in the country and in the world. And at times, it depends where the situations are, it may be still very expensive for people to use it. However, if you're practicing in different parts of the world where you don't have it, you have to decide whether this, whatever, $100 or so vial is cheaper than another intervention that you may need if you need that information. So you have to kind of weigh your equation. Hopefully we can use it with 3D. For perfusion, this is my opinion at this stage of the game. It is technically demanding, not approved for perfusion still, not competitive nowadays with other modalities that we have, and we have quite a few, and there is, although there is a utilization code, it is really great for research, no question about it, particularly animal work. Role in therapeutics, you need to know that when you give high mechanical index and destroy these microbubbles, part of the utilization of gene delivery or vector delivery is you could load these microbubbles with whatever agent that you want and then image them with high mechanical index so you can destroy them. Actually, with very high mechanical index, if you don't have any protection or if you're just on top of the organ, you could have some microcapillary disruption and extravasation into the medium. So if you see some of these applications are for gene delivery targeted depending of where the organ is. Thrombolysis, Tom Porter actually has pioneered this, and in helping on the way to a PCI procedure, an acute myocardial infarction, because the high energy combined with contrast can enhance thrombolysis. And some experiments regarding vasa vasorum imaging when you have high plaque, soft plaque, I think still experimental, if you will. So that's what I wanted to share with you, and if you have any questions, I would love to answer them. Thank you very much for attending. Any questions from you or from the audience? Yes, Mahmoud.
If you have a study where initially they did non-contrast, the last set of images they injected contrast, and you had a good TR jet for the non-contrast, but then that TR jet obviously is a little bit more accentuated with contrast. What do you use for PA systolic?
The question is, if you have a TR jet that was seen, well delineated before contrast, and then contrast was used, and it was a little higher afterwards, which one do you use? We'll use the non-enhanced contrast. Actually, we didn't publish it. It was an abstract presented many years ago. We took patients with TR jets that are soft, not too hard, enhanced them with contrast. On average, if you take very, very early on, it is the peak velocity is increased by about half a meter. So 50 cms per second can be bloom. And gradually will die down when contrast come down. So we know you will overestimate. And remember, all the validation against hemodynamics were done without contrast use. So if you increased, you're going to overestimate it. And we know also from early data that if you use all the way to the very soft speckles on the spectral display, you will overestimate your pressure measurements. Other questions? Yes?
We've seen sometimes that once you go from a non-contrast to a contrast image, the EF estimate is a lot lower on the contrast image. Is that just a function of that the non-contrast image is foreshortened, or is there an actual myocardial effect of the bubbles?
I think from experience and from data, it is not an effect on the myocardium. It is either an overestimation or a different visualization. Hard to tell. But I think it's realistic that what you see with contrast, provided it's not foreshortened, et cetera, that you get the images correctly. One thing for the sonographer is once you have contrast and if the images were not as good, you have to reposition your transducer to get your maximal best visualization, which may be different than when you were struggling with just before. At times the RV may look a little different, and I cannot have a definitive answer for you. I think it's probably okay that we at times overestimate with RV, when we know RV systolic function compared to LV systolic function is a little less to start with. Other questions?
Dr. Zoghbi.
Yes.
So the contrast, would that influence the measurement for the LV quantification, or if we have a non-contrast, should we, decent non-contrast, should we go for that for the LV?
The question is, with contrast, how does it change your measurements, et cetera, et cetera. We know that non-contrast images, ventricular size, probably not as much function, because ventricular size, diastole and systole, is smaller than any other CT or MR imaging. Part of the reason is what you see enhanced is the interface between blood and the trabeculations of the heart. Interestingly enough, if you go 1 or 2 millimeters further into the trabeculations, you think it's small, but actually it increases volume conceivably, depending on the size, from 20, 30 cc's to at times 60 or 70 cc's. So from all the data from Roberto Lang, from Mayo Clinic, et cetera, is that use inside whenever you don't have enhanced images. When you have enhanced images with contrast, ventricular size increases significantly because you don't see anymore the trabeculation, and it will stop at the hardcore myocardium as opposed to trabeculation. Still, overall size in large ventricles is underestimated with echocardiography because we don't use similar methodologies. And two, most likely there is some foreshortening in these very big ventricles. So if you take a look at normal size ventricle, I think you're pretty close. As the ventricle gets bigger and bigger and bigger, you will see a consistent underestimation with echocardiography. And it could be related to some of the assumptions, method of discs, and also some foreshortening of the apex. Any other questions?
Yeah, I just want to add one thing. I think what Safi has mentioned is very important, and when you're meeting with...
It's close to you, so you don't have to travel.
Yes, I think what Safi said, he was talking about like what cutoffs we use when you use contrast versus non-contrast measurements of the ventricle. I always say, like, when you use contrast measurements, you're getting away from guidelines but closer to truth, maybe.
Yes, that's true.
So you have to kind of weigh it, like, as to which number to use. What is the clinical scenario? Is there an explanation for possible LV enlargement, for example? So you have to put it together. I consider myself lucky because I read MRI and I have an idea as to what the ventricular size ranges are for normal and what is mildly abnormal. Sometimes I use those to kind of get an idea as to when I do contrast, what is the size of the ventricle, is it truly enlarged or not. The second thing I want to say is, since it's a slide about future directions, there was a study actually recently, I think a few months ago, in black imaging, using contrast for measurement of intraventricular pressure. So like LA pressure, intraventricular, which I think it's very promising in terms of the future use of direct measurement of intraventricular pressure as opposed to using, the other surrogates that we use E over E prime. And so I think there's a bright future, like the images for this agent.
I mean, going back to Safi's question, I think it's critical when you use ventricular volumes to assess valvular heart disease. I'm not talking about volumes, measurement and volume, because you have to go by the guidelines and the serial changes for that particular methodology. The guidelines of volumes by CT or MR are certainly very different, although it's the same heart in a way, right? But whenever you're going to use ventricular volumes to assess, to quantitate regurgitation, this is crucial. Why? Because you want the stroke volume of this, not an ejection fraction and not a linear measurement of the ventricle. Because otherwise you're going to underestimate it so much and it will affect every quantitation that you would do. Thank you very much for your attention. See you next week.